I hope the recording is fine with everyone. I'm sorry, I should have asked in advance, but if anyone would prefer we not record, please feel free to add it in the chat. It's really just for our purposes to go back and capture any notes and parts of the conversation. Okay, great. So back to the rationale. Again, a lot of work is already done in quality of care. All of you have been leading that work. You have written some of the most seminal pieces on this work. So again, we really want to find where are the gaps and where might we add value. And the third point here, I think is important, that we really do want to kind of hone in a little bit more on empathy and compassion in particular, and in the time after labor and delivery. There's a ton of work that many of you have been involved in around respectful maternity care. So we really want to look at that time after birth and try to see what more we can do around compassion. We know that compassion can heal, it can promote human connection and a real culture of caring, which is worth emphasizing, and that there are mutual benefits, not just on the side of the client, but absolutely on the side of the provider. So we really do want to make sure that this activity is focused both on clients as well as the providers who serve them. And many of you are providers yourselves, so I'm sure you will bring that perspective to the conversation today. And then finally, the goal with this core funded activity is really to design and test an intervention in a low and middle income country to improve experience, again, for both the client and the provider. And we're really expanding the definition of postnatal and postpartum. So initially, when we started the Lit Review, we were looking at the first 12 months after birth. Again, not focusing so much on maternity care, but a lot, or labor and delivery, but what happens after. And in subsequent conversations with some of you in your projects, people have also suggested that we look a little bit beyond at child health, beyond infancy, given that there are some gaps in that area. So we're being a bit flexible here with the time period, and we haven't landed on where we will focus. So I just want to throw that out there just to clarify kind of the terminology. And if we move to the next slide, here is kind of the vision of what we're planning. We've done a rapid desk review, and by rapid, I mean rapid. Again, so many other folks and many of your projects, many of your projects have already been collecting evidence. There are lots of different resources. There's the Align site, MKA has done just incredible work. MCGL did a lot of work and particularly focused on empathy, which is absolutely of interest for this effort, and many others. MCSP, before the current momentum, so lots and lots of work. Our job is not to collect the evidence or even do a systematic lit review. It is to kind of synthesize what is there, see how we might be able to apply it to an intervention in the period that we're discussing. So today, the consultation here is really to invite all of your perspectives. Some of you are really well versed in the evidence in the peer review literature, and that's fantastic. Some of you are working in US settings, really doing a ton of amazing work around compassion and empathy in healthcare. And we invite those perspectives, really trying to bring kind of a diversity of opinions to this discussion. So we're going to unpack the factors that we have found. And the vision really is to say, we have this peer review literature and gray literature as a foundation. We absolutely need to start with what is, recognized as global best practice and proven to work, and create some space for potential innovation and other ideas that can come from that. So really just looking to have more of a conversation with you all today and invite your perspectives. From here, we will hold a second consultation. And again, in between these two consultations, we're really hoping to identify a country for implementation. And so the next consultation and discussion will really be a co-design process in a country yet to be determined, because of course we shouldn't be designing an intervention from here. So that is the plan. I mean, we might be overly optimistic, but we're hoping for September. And then we want to use some time after that to develop and refine the intervention further and do a bit of a pilot of it and start thinking about how we might evaluate that down the line, assuming that funding will exist. So if we move to the next slide, this is the last one for me before I pass to Tina. Also want to highlight what we are not doing. As I mentioned, we're not conducting, and we did not conduct a systematic review. So many others have already done that work. So we really want to leverage the other USAID investments to date, and also draw on some of the literature outside of maternal child health that we've been looking at across our project. Again, I mentioned all of, many projects who have been pulling together this information and have done incredibly thorough lit reviews already. We are hoping, the second bullet here, that we really don't want to duplicate efforts. We're looking for synergies, for opportunities to fill a gap, and really coming with some complete openness and humility that we want to hear from you, learn from you, not duplicate, and just share, even from a basic knowledge management perspective, so you know what we are doing, and we can stay in touch and really welcome that partnership and collaboration going forward. Thirdly, we're not designing a training package. Many already exist. There's amazing work already out there. And so we want to think about developing something that's more multi-level, making sure that we're taking different levels of the system into consideration and trying to find ways to create impact, again, both for the client and for the provider. We are not focusing on the client alone, as I mentioned. We have certainly seen in the literature, and we're reminded on a call just the other day by colleagues at MCGL that mistreatment and disrespect aren't solely experienced by clients. And, providers are dealing with incredibly stressful, complicated situations within the health system that are not always terribly supportive of them. So we really want to make sure that the emphasis on providers in this activity is equal to that of clients, and that there is a prioritization there. The next point, we're not defining experience of care or person-centered care in a vacuum. We absolutely recognize that quality of care is culturally informed, and that's why the co-design process will take place in a country and really be driven by the context of that country. Yet, within that, every culture has supportive elements to it, and we're hoping to leverage those and really try to figure out how we can possibly shift some of those dynamics, and make sure that we're also acknowledging some of those dynamics, that there are very real power differentials that take place within a facility setting, outside of a facility setting, recognizing that there's implicit bias, there are social determinants that operate within a society that shape those interactions, that shape clients' behavior, provider behavior. And so we want to look at that universe and recognize the complexity of it, but also recognize the interactions between them. So we're not deciding on a country of intervention today, but absolutely welcome your ideas. As I mentioned, Breakthrough Action is working in maternal child health in several countries, but we're completely open and welcome partnership with any of you, and in the country settings where you might be working in, if you see that this might add value or amplify the good work that you're already doing. So it's really an open invitation for partnership. And then the last point here is again, this is core funding. So we are starting with a relatively small pilot, but the idea is that ideally this will have global application, and recognizing, of course, that every country is different and adaptations must be made. But we really hope that this will add something to the global evidence base. So with that, I will pass to Tina to walk us through the details for today's consultation.
So today our objectives are really to present some of our learnings, but like Len mentioned, really it's to learn from you all as experts in the field and working on existing programmatic efforts. I think the part of sharing out, we will be identifying some of the influence factors that we identified mapped along the PPC ecosystem, which we will talk very high level about. And our goal here is to also just essentially briefly look at the influence factors that prohibit as well as inhibit providers being able to show respect, empathy, compassion along the postpartum period. And we are defining postpartum here as up to a year. We're hoping to be able to discuss some of the related programmatic efforts, as well as just being able to talk about what are the gaps and opportunities that you all have seen in the field. In terms of just quickly aligning on working definitions, so you all received this in the pre-read already, and I think the talking point here is really just, we want to be able to align on these definitions, but also recognize that there are many different ways to approach, how to think about quality of care, experience of care. There's quite a few definitions out there. I think what we wanted to be able to do is focus on experience of care, I think, which places the provider and the client at the center of the universe, if you will, being able to understand, what are the different components that go into a provider's behavior, as well as how does the client experience get impacted throughout. We did not so much just focus on the person-centered care. I think in this particular case, I think that does place the client at the center of the universe, and we felt that experience of care is able to be a bit more expansive when it comes to incorporating the provider view, and that's a big component that we want to explore today. So this also was shared in the pre-read. I think in terms of the landscape of interactions, like I mentioned, we do want to focus on the first 12 months after birth. And we do understand that, I think there's quite a bit of different emphasis on some folks have done a lot of work in the earlier stages, perhaps the first 3 months after birth. And then there's also emphasis on early childhood. I think we want to have a discussion with you all to understand, as we're thinking about co-designing an intervention, where are the different service points that could happen, and where are there gaps? So being able to, open it up to discussion today to understand, where along this timeline would we want to design an intervention, where are the biggest gaps and needs, and be able to learn from you all here. In terms of the outcome, so I think our emerging theory of change, if you will, is that there are influence factors upstream. We do want to take a look at all of the different influence factors in the ecosystem and ideally design a multifaceted intervention. So it's not necessarily just one tool or one intervention, but a full intervention that can be able to address across many different influence factors and be able to have these general outcomes in mind. So we are looking at, like I mentioned, the client outcomes as well as the provider outcomes, and be able to achieve positive responses for both. And to date, I think a lot of the research that we found were focused primarily on client outcomes. And for us, we want to be able to improve both. Just briefly in terms of our DES review. So we did focus, like I mentioned, up to that 12-month postpartum period. We were looking at mothers as well as newborn child health, including, provider behavior, experience of care. There's quite a few additional keywords and search terms that we had in our methodology, but we wanted to include a few here. I think the goal, like Lynn already mentioned, is that we really wanted to leverage and utilize existing lit reviews, systematic reviews, meta-analyses that existed, and not redo any research that's already been done. So it's a very rapid desk review where we wanted to take a look at everything that others have done, build upon it, and be able to share out some of the initial findings, but really use that as level setting.
Great. So this also, I think these slides were also included in the pre-read if you had a chance to take a look at them. So I wanted to introduce to you the provider behavior change ecosystem, which was developed under the Breakthrough Action Project. Some of you might have seen this before. Some of you on this call might have also been involved in developing it. One of my colleagues will post a link in the chat while I'm speaking so that you can go to the site, because on a static slide, we can't really convey all of the functionalities of the ecosystem. It was developed through various stages of literature review, consultation, and testing. It was originally developed based on family planning literature, but it's been used in the context of malaria and other health areas, and now increasingly looking at the application in MNCH, because a lot of the provider factors and behaviors are similar regardless of health focus areas. And it's essentially a tool to understand the diverse factors that influence facility-based provider behavior and to understand how those factors interact with each other in a system. And if you go on the website, you'll be able to see when you click on one of the factors how some of these are linked together and how they interact. And really to think more holistically about provider behavior change. And then lastly, can be used as a tool to provide a framework to help design, implement, and evaluate more supportive, effective PBC initiatives. So this is really understanding that this is a complex system and there's a lot of overlap and interaction. So encourage those of you that haven't seen this before to please take a look at all the great materials that are available online. And so just to dive in a bit further, this is pretty comprehensive, but we wanted to lay this out. So essentially the PBC ecosystem looks at all of the different influence factors that will have an impact on client-provider interactions. They're categorized into 7 different groups. The individual provider, the individual relationships, so the relationships that a provider might have, personal with family, friends, etc., and others. Looks at factors related to the client, community context and social norms, workplace environment, health governance, and then looking more broadly at the country and geopolitical context. So you can see this is fairly robust, fairly holistic. There's a lot of sub-factors as well. We use this as sort of a baseline and a framework for us as we were doing our desk review, looking at the factors that were cited in literature that had an impact on experience of care, and then tried to map these according to this ecosystem. And so we can go to the next slide. You don't need to go through all of those in detail, but just to show sort of comprehensiveness. And what we've done, the literature review that Tina just described, we look through where are there explicit cases in literature where some of these factors, or there were factors that were cited as having an influence on experience of care. And we've grouped them based on the categories of the PBC ecosystem. Most of these factors, so we have about 32 factors, and there's some sub-factors, which we'll go through, I'll show briefly on the next slide, and then also in the group discussions, we'll have a chance to dig in more deeply. The majority of these were pulled from MNCH context. There's a few that are even more specific to the postpartum period, and those have the little 2 subscript after them. And then I think we have 1 or 2 that are looking outside of MNCH. So we tried to be as comprehensive as possible as we pulled these in. You'll notice that interpersonal relationships is sort of a gap in the literature. We weren't able to really find explicit factors related to providers' personal relationships that had that translated to an impact in the experience of care, at least in the literature. So we're going to go through these in more detail, but on the next slide, I'll give you one example. So for each of these categories, we've gone and highlighted, so what were the specific factors that we saw? So in terms of socio-demographic factors, for example, we saw that female providers tended to be associated with providing an improved experience of care. There's also factors in the red column that were cited as having a more negative impact on experience of care. So for example, a lot of things having to do with biases on the side of the provider, if they believe the client was rural or poor, older pregnant clients and things like that, those were factors that related to personal biases and prejudices that the provider might have. But there are other things, if we look at the stress and fatigue category, the literature cited that providers having, probably not surprisingly, high levels of work stress or personal stress. Certainly that was a factor cited as having an influence on experience of care. So this is one example. We've done this comprehensive review for all of the factors that were listed on the previous slide. And so when we go into our breakout groups, we're going to split up and look at some of the categories together in a group. So you can go to the next slide. So those are the influence factors. We've also, as I think Tina mentioned, took a look at all the different interventions and tools that we could find that were related to trying to improve experience of care between provider and client. Likewise, we've categorized these into different buckets. So there's various different levels that we can think about these, but we have certainly found tools related to more policy or guidelines, a lot of processes and protocols. That was really a lot of the materials that we found. And within those categories, we've listed some high-level examples. And then within each of those subgroups, there's specific tools that we found. And we have a long list of tools, many of them coming from the great projects that people on this call are working on. And we've tried to pull together sort of the comprehensive list of what we know to exist and to use those as inspiration to think about what are the different types of interventions and tools that might be pulled together in combination for this particular project. So as I mentioned, policies and guidelines, processes and protocols, there was a lot of trainings and exercises. There were some really interesting psychological interventions and tools, and then certainly community programs. And what we've tried to do also here is to think about, for each of these different interventions and tools, which of the influence factor categories are they most relevant for? And you can see that there's also a lot of overlap. Some community programs would certainly have an influence on the client, but also on social norms, etc. So that's just a very quick overview. And then just to kind of conclude this section before we open up for questions and then have the group discussions after, just to do a quick recap. So our focus on experience of care, and again, we were looking at respectful care, empathy, and compassion. Certainly during that postpartum period, again, 0 to 12 months interaction, we found in the literature is somewhat minimal. There certainly was a greater focus on the client's experience and client outcomes as opposed to providers, which we were particularly interested in. And within experience of care, most of that literature focused on respectful care. There was a lot of language around disrespect and abuse that came up quite often, but really looking for instances and examples of compassion and empathy didn't seem to be as robust in the desk review that we conducted. Certainly understanding there's a recognition of the complex health system and many of the interacting factors that lead to and shape experience of care, which we've pulled in the PBC ecosystem to try to understand how those factors influence each other and to interact to the extent that we can. Also in our desk review, we really noticed there's a limited standardization and agree on the metrics of outcomes and evaluation. If we have time at the end of our breakout groups today, we'd like to dig into that a little bit. Not only the metrics and outcomes, which we think we have plenty of examples of what are the key outcomes and indicators that are used to track, but some of the challenges that are faced in terms of measuring those outcomes. We saw, and maybe you even saw on the previous 2 slides around the different influence factors. There's not much talking about the factors that positively influence experience of care. There's a lot of focus in the literature around what is negatively influencing experience of care, which is potentially interesting to note. As I mentioned, also the interpersonal relationship category. So looking into more deeply the lives of providers, not just their own personal socio-demographic factors, their extent of training, et cetera, but their more contextual background in terms of their family and their relationships and how that might have an impact on how they show up for their work and for their client interactions. And then programmatic efforts, as I mentioned, a lot of focus on trainings and policies and protocols, and then a lot of great emerging interventions and tools around community programs and more interactive activities. So I think we're going to pause here for some questions. We have about 10 minutes for this discussion, and I'm going to take a look at the chat as well. I think there's some good questions there, and if people want to also come off mute and ask questions, now is a great time to do so. John, I see you put a question in the chat on the strength of evidence for impact as a universe of interventions. I think we saw that that was varied, and I should also have mentioned that we have that sort of full long list of the interventions and tools that we believe are relevant for this context. A lot of those are still in progress. We included them as well as interesting examples. So some there are no evidence yet, and some we have some literature and even peer-reviewed articles for. We have some case studies that I think we would include when we send out this deck in the appendix, to show in the case where we have actual examples of odds ratios and things like that. So we have some good data on quite a few, but it's really varied across. And any of my colleagues that would like to jump in and add to that, please feel free to do so.
Not to add to that, but maybe I'll just jump in here. I see Bethany, thanks for the question around post-abortion care. And Tina can speak to this if anything came up in the literature around that. I'm not sure that was part of what was captured in the search, but we had not been planning to focus on post-abortion care. We were not planning to highlight that in this work. But again, if you have suggestions or things, there are some other elements we should be considering and haven't, we welcome those. Sorry, Jessica, back to you.
No, thanks so much, Lynn. I'm reading the question or comment from Dinesh, and just wondering if you want to come off mute and clarify the light arrangement in facilities. I think we did find, and again, the factors that we noted on our slide and that we'll be going through together are ones that were explicitly mentioned in literature. And we obviously are aware that there are many things that have not yet made it to literature. And that's part of the great discussion we're hoping to have in the breakout groups. But there certainly were a lot of points around the actual facility environment and cleanliness and busyness and et cetera. So just curious, wanting to make sure we understand your question around the mention of light arrangement in the facilities. Feel free to go off mute if you want to further clarify that as we look through other questions.
So if Dinesh isn't going to expand on her question, can I go ahead and ask one?
Yes, please, go for it.
Hi, this is Carol. First of all, congratulations. I think this is excellent and very comprehensive. Thanks for the overview. My question is about the need to understand interpersonal relationships of providers. I wonder what we would expect to gain from that and what we would be willing or able to do about it.
Excellent question.
So can I come in?
Yeah, Dinesh, if you don't mind, I'm going to respond to this last question, and then can you clarify after that? Would that be fine?
Okay, no problem.
Okay, fantastic. I just wanted to call out that's a fantastic point. I think we'll see as we go through some of the detail of the influence factors we found. Not all of them are actionable. So we certainly can't change the gender of the provider or the age of the client. There might be some interesting things to do around the biases associated with, for example, the age of the client. Both at the community level and at the provider level, but definitely out of that list of the 32 different factors that we found, not all of them are actionable. So we've done some thinking already as to which are most actionable in general, which are most actionable for an SBC intervention, what are most relevant for looking at that postpartum period. But absolutely, some of these are factors that were certainly cited in the literature, so we wanted to make sure our list was comprehensive, but there's certainly some things that we would be hard-pressed to design an intervention or tool that would address. And just want to clarify, did that answer the question before we move on to Dinesh?
Sort of. I mean, I was asking specifically about the interpersonal relationship part. Not, I mean, the demographics, obviously, we can't change. And even, I guess my question is, so part of it, it seems like it would be, even if I were a provider, I wouldn't want you asking me about my interpersonal relationships. And as a program, I guess I'm wondering what we would gain from knowing about that and whether we could do anything about it. So the relationship of the provider with other members of her family, with her spouse, with her whatever. I guess I'm just not sure there's a lot of value in trying to dig into that.
Yeah, it's a great point. I mean, there's nothing in the literature that we found. I think we wanted to keep it sort of as that placeholder to illustrate that there does seem to be a gap in that area. I tend to agree with you to not be sure what thinking about how some of those relationships might interact or might influence the provider-patient interaction, but we wanted to leave it as an open question to see if anyone in this group from the experiences has seen something that might be particularly interesting to explore.
Yeah, and maybe to agree, Carol, that's probably not an area that the intervention will look at. We wanted to just map all of the literature and the great literature and experience against the provider ecosystem, and that is one of the domains within the ecosystem. So we're not saying that we are going to, or even would suggest intervening at every one of those domains or levels, but we would probably do multiple levels, though that's one that, you know, likely is not one where we would focus.
Great. Dinesh, did you want to come off mute?
Okay, so thank you for giving me time. So actually what I wanted was that, you know, many times what we see is because people work in this labor, you know, wards for prolonged periods, and the lighting arrangement is never considered as a, you know, sort of influencing them on their behavior. So that is what I was, you know, focusing on, that, you know, that should also be included specifically, because that doesn't actually, you know, many times we don't take into account the lighting arrangement which is there, because that's, you know, 24 hours, the same light, white light is being used. It's not a relaxing thing for them. So that actually influences their behavior.
Thank you so much for clarifying. I had sort of thought that that's what your point was, but just wanted to make sure. I think that's an excellent point and an example of something in that workplace environment that maybe we didn't see explicitly in literature, but could be a potentially very interesting factor. And I think about some of the tools we found around the psychological angle that some of the interventions have taken. There's a lot of things to try to reduce stress and meditation and things like that. But to consider how you know, fluorescent lighting or dim lighting actually has an impact on the, you know, the psychological well-being of providers who are there for very long periods of time. Potentially an interesting avenue to explore in our breakout groups. So thank you so much for raising that. We have a very busy chat. I'm not sure we're going to be able to get to all the questions. I don't know if any of my colleagues have picked and seen a few that maybe we're able to address. Otherwise, I'm going to scroll through and see if I can find some that I can answer as well.
Yeah, thanks, Jessica. I'll tag team with you. I'm trying to respond to some really excellent points and things to be mindful of. So John, I had raised a question around, you know, it's great that we're looking at several people actually across different domains, but the complexity is real, and it does make the design sort of challenging if we're looking at so many different elements. And it's a real challenge and will be tricky to manage. So we do indeed need to be mindful of it. And Rebecca, yes, facility leadership is absolutely recognized as one of the factors. And I think part of that is in the workplace environment. I don't remember all the different domains from the PB ecosystem, but it's quite comprehensive. So it absolutely does include that. And thanks for your note about what you've been seeing in the immunization sector. Right, another note about the complex system level interventions and how we're marrying sort of the SBC and health systems, and how can we make sure that we can manage that complexity, and noting a great example of respectful maternity care intervention in Kenya. I'm not sure which one you're referring to. If you want to add the name in the chat, we welcome it. We may have already captured it. We'll just have to double check. Suzanne, bit of nursing literature on compassionate care from high resource settings. Great. And I think calling out the point further up that Beth made from the Schwartz Center is really important. You know, and thank you for that, tweaking the definition that, you know, empathy is that kind of ability to understand and step into the shoes of someone else, but compassion is sort of that empathy in action, and it is very actionable. So thank you for that. And yeah, appreciate that point as well.
I think we have time for one or two more questions before we go to breakouts. And I know there's a lot of questions. If we're not able to get to all of these, we're recording the conversation and we're going to do a real thorough look through the chat as well, so that we can respond to questions after. So I see some hands go up. Kathleen or Shams, I wasn't sure who had their hand up first. Maybe Shams, and apologies if I'm not pronouncing your name correctly. And you're on mute.
Yes, indeed I am. Greetings, everybody. Just very quickly, the linkage with primary healthcare, I think it's one that we should be considering, and thanks for all of the work that you've been doing on this. But I'm just wondering how that, particularly in the light of all of the work that WHO and UNICEF have done on the primary healthcare operational framework and the 3 interdependent arms of primary care and engagement and empowerment and multisectoral policy. I'm just wondering if all of this excellent work is framed as being connected to the engagement and empowerment piece, that has an opportunity to really shift systems in line with the intention that's very clear within this work. And I just wanted to sort of also bring in the definitional piece. Colleagues have already mentioned this, but I think it's really important to be very clear about the definition of compassion. And the working definitions may need a little bit of tweaking to ensure that the compassion piece reflects the empathy plus the action that Lynn, that you've just mentioned. And finally, just a comment, because I unfortunately won't be able to keep the whole 90 minutes, but there is some work from WHO that is emerging on relational community engagement. And this is also speaking to the point that was being mentioned earlier on that human interaction piece, and particularly thinking about the science of human interaction within the services and the systems. So not just at the point of care, but how do services and systems think about human interactions to mold the health systems of the future? So that's something that we could certainly share. There's some work that's emerging in Laos, Cambodia, and in Malaysia that we could be able to share in the coming months. So just a few quick points from my side, and a particular question on the primary healthcare side. Thank you.
Thank you so much. I mean, really, that's fantastic. Also, not only for the compassion definition, we're very open, and really one of the major points of this consultation also is to really get that great feedback, some of the definitions in terms that we're using, how we can improve them, and very, very interesting on the relational community engagement component. I think that's something that we definitely were very interested in exploring further. The primary care component, I think it's something that we haven't considered as much. I think that's also just a really interesting area to explore. I think what we've been thinking of so far is to consider around the slide that my colleague shared a bit earlier, and all of the different specific points of interaction around that postpartum period, to see if there's something that's more or less relevant there. But I think thinking a little bit more holistically as well, and thinking about how those services integrate into broader care is particularly interesting. I'm not sure if any of my colleagues want to add on to that. I have a bit more thoughts. I think it's something that deserves further exploration, and probably we need to think about a bit more. So thank you so much for raising it. I see two more hands up. So maybe in the interest of time, so that we can keep the schedule, Kathleen and then Simone, 2 more questions, and then we'll cut to breakout so we can continue discussions in smaller group as well.
Yeah, thank you very much for the very clear, thoughtful presentation. And I appreciated Sham's point about linking to primary care. And actually, I think if you are considering the postnatal period as an extended period in that first year, then I think the primary care perspective really makes a lot of sense, because you're talking about, linking to primary care services related to family planning, to child, infant health, et cetera. So I think it would be a very natural synergy. One I guess question I had posed in the chat is, I think as we're all highlighting, the definition or the constructs that that are inherent in experience of care for both provider and for client are many and are complex. And given your focus, as well as the interventions, of course, which I know we would all agree on, given your focus on compassion in particular, as I'm hearing, and I appreciate the comments about sort of distinguishing between empathy and compassion, and but given your focus in particular on compassion, and given how complex it is to work on experience of care, I'm just wondering to what extent your evidence review identified, interventions and sort of measurement frameworks from any resource setting or any technical service delivery area related to compassion, because that's, for me, quite a complex area to influence, probably more complex than like provider communication, which is also very related to women's experience of care. So just particularly interested in your evidence review with respect to the compassion piece specifically. Thank you.
I will let my colleagues answer with more further answers, but I think we did, also across interventions and looking what different indicators people have been tracking and comparing that to what we found in literature as well. I think there is a gap. I don't think we saw a lot of, breaking down the types of measurement of, particularly of compassion. There didn't seem to be anything that was, robust and tested. that comes to mind for me, but I'll pause and see if my colleagues, maybe Tina or Malika, who've gone through, but it seems to be a gap that potentially is something that I should mention as well in the next phase of this project, after we've discussed and in the next country consultation, have co-designed probably a holistic set of interventions that will work together. We are going to develop a monitoring and evaluation plan. So it could be potentially very interesting to see how exactly we are going to, or what we might suggest, pulling from the literature that we found, again, which I think is not that robust, and certainly would love opinions and thoughts as that's pulled together. But let me see if my colleagues then can add a bit more thoroughness than my quick answer.
Tina or Malika, did you have anything to add on the compassion measurement of what was found?
Yes, I think one thing I can add is that we were looking as we were doing the case studies on, Heshima, or the case study around care around birth approach. There was not a lot specifically called out on compassion in particular, but we did see some studies or intervention using frameworks such as the CARE score, which measures on a Likert scale how satisfied a patient is with their provider interaction. So again, a lot on the client side, which is and a little bit of that was linked to compassion, and also patient surveys, but nothing on the provider side at all, and not a lot in general on compassion itself.
It's a bit of a difficult concept also to translate into metrics that can be replicated and validated and used more broadly. So potentially an interesting gap to look into. We're running a little bit late in time. We want to make sure we have time, but I know, I promise, Simone, you've had your hand raised for a while. So maybe can we take your question and then do move into breakout groups?
Sure. Thanks very much. I'll try and be as quick as I can. I'm just curious to know, maybe I missed it, the focus on postnatal care versus antenatal care. I'm wondering whether there would be scope to extend that into antenatal care. In my experience, many women in low and middle income countries connect with the public health service in the antenatal period predominantly, and that postnatal care is often patchy outside of possibly the well baby or the immunization visits. So I'm wondering if we're losing an opportunity by taking away the potential scope for work in the antenatal period. It's obviously my agenda and where I'm working predominantly, but I think we may have a possibility of getting greater bang for our buck because of the well-established high levels of obstetric violence. I'm just wondering if there's scope to include that in the scope of the project, but don't want to railroad the agenda. I'm just curious to know as to why postnatal predominantly.
Yeah, thank you so much, Simone. Definitely agree that there are synergies across, and I think it's hard to hyper focus on one particular area when they are so interconnected, and it would be interesting to look more holistically. I think the intention that we had was to really find an area where we're not duplicating all the great efforts that so many others, including yourself, are working on. So we wanted to try to find an under scrutinized space or a particular area that hasn't had as much work done to date, which is why we honed in on that particular period. But I think, evidence of having all of the great experts on this call today, which are some of them, many experts in that antenatal care area, is that we want to make sure we're looking for the connections across as well. So I think we are still trying to hone in on that postnatal period, but pull from all of the great evidence and work that has been done in other areas. I don't know if anyone else, my colleagues, would categorize that differently or want to pull out any particular points that might be relevant for that as well.
No, just agree with what you said, Jessica. Just one other thing from the chat, if I may. I know we need to move on, but Pooja, I just wanted to clarify. I think you had made a point about interesting that we didn't find as much interpersonal relationships between providers and patients. That's actually not the case. We found lots. The interpersonal category, or the name of it in the provider ecosystem, may be confusing, but in that ecosystem, those factors are really specific to the provider. So their interpersonal relationships with their husband or their family or their friends outside the facility. So apologies if that terminology threw things off, but we did absolutely find quite a bit around patients and clients. And Shams, thank you so much for adding all of these great resources in the chat. Back to you, Jessica.
Great, thanks so much. I think we're going to move on. We will have more time, and I think our intention also was to break us up into smaller groups so that we can have more of that free-flowing conversation as well. So it's not just, you know, back and forth between us, but also across and among all the great people that are joining on this call today. So we've, the intention is that we'd have 2 breakouts split roughly in half. I think I can mainly stick to what's listed on this slide here, with some exceptions of some people not having joined in things, but this is roughly the groups that we'll be breaking into. One group will stay with me in this main room, and another group will join Lynn and Tina in a breakout group. I think we're going to have about 25 minutes for the breakout group. So we want to make sure we have time to come back and share at least a little bit what we discussed, and then also to talk about next steps. But essentially, we're going to be breaking out, looking at influence factors. So again, across all of those different categories, we're going to break up into 2. And really the focus here is based on all of the great knowledge, experience that everyone on this call brings to those conversations. Where are the opportunities and gaps that we see, both in terms of the influence factors, but then also thinking through some of the potential programmatic gaps and opportunities based on some of the high-level landscape that we've shared with you today. So those are the general questions we have. We're going to be doing this in Jamboard. Hopefully people are familiar with that. It's basically a PowerPoint that you'll have access to and be able to add sticky notes. But once we break out into groups, I'll be facilitating one group, Lynn will facilitate the other. We're going to give a little bit of an intro and further explanation as we break into that. So the link to the Jamboard has been put in the chat. For group 1, you're going to start on page 1. For group 2, we'll start on, I think, page 6. That's all we have here. So group 1, so again, that's Lynn leading that group here. You're going to be focusing on the factors related to the provider, the workplace environment, and the health system governance. My group will be focusing on some of the client factors, community context, social norms, and country and geopolitical context. We tried to find some that fit together, but of course, as we saw in the ecosystem mapping, all of these are interrelated, of course. But for the purposes of simplicity, we're trying to just break out into two groups here. So without further ado, I'm going to open the breakout groups. So you'll be requested, some of you, to leave the main group and join your breakout group. I'm going to put it for, I think I should actually put it for 20 minutes at this point. So sorry. I just want to make sure we have time to really share findings across as well. So I'm opening the rooms now. You should see a pop-up to allow you to join that other room. So, thank you so much. Great, yeah, I think everyone's in the right rooms now. So what you'll see here is, as I mentioned, so I shared a very high-level simplified version. Like, maybe you can make that full screen, just so it's a little bit bigger. Thanks. So there's 3 slides, one for the client, one for community social norms, one for country and geopolitical context. And so this looks similar to what we discussed in the plenary or larger group session, but we also included a bit more detail because we thought that's often helpful. We included this in the pre-read, but we understand that it was just too much information to try to share for everyone to look through before this consultation. So essentially what you'll see here is, for the client, for example, on this particular slide, there are those 7 factors, but then within each of them, there are maybe even some sub-factors. In the columns that we have, the green and the reds are your sort of simple cheat sheet, which is boiling it down. What is the key point that we heard, which contributes to a positive experience of care? And then in the red, what were the factors, or the kind of the shorthand explanation of the factor that we saw had a negative impact on the experience of care. And then in the findings column, we described a bit of what we found in the literature, and you'll see there's footnotes there that link to bibliography that we have in the appendix of both the pre-read and also in the documents that we'll share out today. So that's not our full exhaustive list of literature that we went through, but it's those that link to these particular factors. So feel free to navigate around. So we have the client and the provider. Actually, maybe if you go back to that, I just want to call out a few. So again, similar to the comments that we were having in the full group, not all of these are actionable, but interesting to note that there are some factors certainly related to the sociodemographics of clients that might influence if they have a more positive or negative experience of care. Disability status and HIV status, likewise, potentially not very actionable in terms of an SBC intervention, but we wanted to note that from the literature. Things that we think might be particularly interesting, and I know something that's probably come up in conversations around how do we actually measure effectiveness of our interventions is the point around uninformed, fearful, or shy clients. So that's under number 5. If you have an underinformed client, one who is shy, even if you have a great intervention or tool that might help improve the experience of care, will you be able to get proper measurement, or will that client be aware of what good experience of care looks like versus what they have in status quo, for example. Number of factors related to their previous experience in birth and delivery. And I think very interesting also, potential opportunities around male engagement, this last point. And male engagement is certainly a topic that's very important. To what extent is that an opportunity and something we might consider for improving experience of care? You can flip to the next slide. And again, as I'm talking, feel free to kind of flip through at your own pace. Community context and social norms, there are quite a few characteristics and factors that we found in this area. So really, what are the beliefs that society by and large, or the communities in which these facilities are located, have that might impact both the client's beliefs, the provider's beliefs, or just the general backdrop by which these interactions are happening? So there's certainly one around belief as men and decision makers. To what extent is that impacting? Some of these that relate to some of the biases that we saw, so lower status of women, gender sensitivity. There's definitely some gender norms in the community that might influence that experience of care. Social stigma and discrimination, an interesting religious norm that is probably quite specific, but potentially interesting for the postpartum period. And then some of these more cultural norms and barriers around experiencing care. Also potentially interesting around unmarried adolescent mothers and how social norms and stigmas around that might be impacting their access and experience of care. And then lastly, the country context. I think if you can navigate again, thanks. The country and geopolitical context. So what are the policies and processes? What are the regulatory bodies that exist or do not exist that may have an influence on experience of care? These also might be, they might be actionable, but it might be less feasible for us to address some of these with an SBC intervention, but nevertheless interesting to consider any intervention or package of interventions that we want to roll out in a given setting will be within this further backdrop of kind of larger policies and regulation. And so go to the next slide, which you've already seen in the plenary group. But looking at what is the overview of existing interventions. And so the exercise to finally get to, excuse me, the actual exercise. What we're trying to do on the next slide, Malika, if you can keep us going to the next one. So the conversation that we'd like to have with the group, if this makes sense, is what are some of the opportunities and gaps that we see, first and foremost around the factors that we saw. And so not necessarily individual factors such as the age of the client, for example, but what are some of the broad trends? So around gender sensitivities in facilities, is there a theme around male engagement? Is there something around just broadly policies and procedures? The note around the shy/uninformed clients. I'll give you a few minutes, of course, to take a look at some of the factors across and see if there's any sort of lines we'd like to draw across some of these that we'd highlight as opportunities. And then also, given all of your experience, what we've listed on these slides are things that have been explicitly mentioned in literature, but are there any gaps that you think we should be considering with regards to the factors that you didn't see appear that you think would be particularly important? I'll pause there and see if there's any questions. And also I see some things going on in the chat, but I'm not sure if it's my group or the other group. So let me see. If anyone put any questions in the chat as I was talking from this group, please feel free to go off mute and ask away.
Hi, this is Allie. From Ideas 42. I put a quick note in the chat and just wondering, you just went through the 3 categories in which you all kind of delved into the literature, but one thing was briefly mentioned in the plenary that I saw was missing was around the health facility environment and, relationships with other providers, some of those health facility dynamic pieces, and just wondering if that was intentional or if that's something you'd kind of want us to put on this gaps and opportunities worksheet.
Yeah, thanks so much. I think it's one of the topics that's covered in the other group. They have workplace environment, but that doesn't mean we can't note it in our group as well. And I think Malika, you might remember, or we can even flip to the slides in the Jamboard to see what's listed there. But interactions across providers, I think, is something that we didn't see identified in the literature that would be a good gap to put in. So also, if people are comfortable with Jamboard, feel free to take a sticky note. So on the left-hand side, there's a navigation bar. I think it's the 4th one down, which would be to add a Post-it note. Feel free to add Post-it notes yourself, or otherwise, I'll actually go in and post that one here. So interactions between providers at the facility.
And just to add on to that, I mean, I think that it plays a part in the community and social norms one as well, when we think about kind of the environment holistically, not just the workplace environment that the other group is covering, but just the social norms of the entire environment, right? And the expectations of the clients. If they have no expectation of compassionate or respectful care, then it's unlikely that that would actually happen.
Yeah, I was just thinking something similar, Christina, that, excuse me, maybe not so much about relationships between providers, but just that whole atmosphere and expectations of, and how you're allowed to treat patients. It becomes a social phenomenon that I think is worth addressing.
Absolutely. Do you see, just building off of that comment, is that something that you've seen in your experience, or do you think it's something that might be an opportunity with regards to policies and procedures, or do you think that it actually has to happen at a more interpersonal level as opposed to just having a policy and procedure around quote unquote how you can treat patients without sort of that social component to reinforce? Just kind of an open question around that, building off of what you said.
I mean, I think you need a policy, but people don't act just because of policy. More often they use lack of policy as an excuse not to do something. So I think while a policy is needed, there needs to be, action at the facility and even district level. You need for the facility manager to set the example and set expectations about how patients should be treated.
Yeah. I was also just going to add from some of our work in Zambia too, the idea that initial work where disrespectful care is no longer normalized. So, whether you have additional resources or training or, clarification workshop to set the expectation that there's going to be respectful care, and then providing the resources for providers to actually do that, and then then creating that shift gradually where you're not seeing that disrespectful care, and so it's no longer the expectation or acceptable to continue providing that type of care. That's where I was thinking about the provider relationship piece as well, and kind of what they see their colleagues doing at the facility.
And just to elevate Lindsay's point in the chat too, I don't know, Lindsay, if you want to come off mute, but about like social accountability and, some level of holding people accountable when bad behavior is seen by other providers or seen by clients or experienced by clients or, all sorts of things.
Yeah, I was just thinking of the comment that Carol had made about, like, you know, a facility manager having some sort of expectation, but then there also needs to be that level of like, okay, and if you deviate from that expectation, something is going to happen, because otherwise, if nobody sees any action being taken when that, you know, bad behavior takes place, then a provider's never going to, I think, feel the motivation to change their behavior. And so I think we need to see that accountability also, or enforcement, whatever you want to call it.
Yeah.
What consequences, right? And I will say,
Yeah,
I will
exactly,
add
exactly.
yeah, and I will add to that, there should also be rewards, even if it's just compliments or kudos or whatever, when you consistently treat patients well. It should be the norm, but it should also be acknowledged.
I love that you brought up rewards too, not just consequences. I think that was Carol. That's fantastic. Just another dynamic that I was thinking of, and somebody brought it up in the larger plenary chat as well, is that, you know, this framework doesn't exactly include pre-service as well. And I think that's an important aspect here, especially when we're thinking about the social norms and the workplace expectations. Those all begin really in pre-service education, right? And so, oh, great, Bethany, I'm glad you added a sticky already. We're like minds, clearly.
Yeah.
So yeah, I think that's important to kind of address. It's not just the workplace, but the pre-workplace, so to speak.
Yeah, that's where most of the behaviors are picked up and where they see it. And then when they are assigned to their facilities, how they're treated by the higher ups as they're, you know, a new graduate or an intern, and it all kind of cycles and spirals from there. And also on the other side, if they're learning, you know, new behaviors, trauma-informed care, something like that, if they're empowered to be able to use those new practices that other more experienced providers might not have, that is a huge both opportunity but also a challenge for these new providers.
Great. I think some of the comments we're getting into intervention gaps. So when we talk about rewards, when we talk about repercussions and things, so feel free to start putting stickies in that area as well. We have about 5 minutes left in our breakout. John and Portela, I see that you have hands up. Do you want to, maybe John, I think, was up first, and then Portela, do you want to come off mute?
Sure, thanks. This is great. I'm sorry that I'm not going to be able to rejoin the plenary later on. I got to drop off for another meeting. I guess in the bottom half of this, and everything I'm putting up is kind of in between opportunities and gaps. It's more like, how do we actually make something useful out of this programmatically? And so the first point I made at the top was, gosh, you know, we're going to have an awful lot of things we could look at. And we did talk about, this is going to be the important thing is some co-creation. We need to be able to figure out ways of boiling down all of these influence factors to the ones that are mattering most in a particular setting. And that's not the facility level, but it could be subnational, maybe national, unless we really think that there's a few things that are coming out of this work that are universally applicable. So that's one comment. The second is, I mean, we have to, from the start, if, you know, we're not academics. I mean, most of us are not academics, and we're not, and a lot of this is coming out of academic research, people who have studied particular issues. We're really trying to look at how do we make something of this programmatically. So as we get into this, we have to think about the intervention in all of its dimensions, including what it's going to cost. Because we keep, I think as a general community, if we're concerned about improving quality of care overall, we keep proposing new things that need to happen to be able to improve quality of care. And this is set, the experience of care, within that overall framing of what do we need to help improve quality of care. And there's limited resources, and we've got to really understand what is going to be what is the way the intervention is going to take shape, because those academic exercises may not really include those programmatic dimensions. So we've got to really make sure we're going into this, because not everything that we can do in an exercise like this, even if we start doing a country level pilot, right? And I think, I wasn't sure if you said it was a pilot or not a pilot, but it should definitely be thought about something that could go to scale. Because the reason is not everything is designed to go to scale. So we have to design from scale to go to scale from the start. So just keeping that in mind as we think this through, particularly around number 2 and the intervention strategy. Over.
Thanks so much, John. Yeah, really great comments and additions. Very much appreciated, and absolutely agree with all of the points you called out. So thanks for bringing those, highlighting those. Portela, did you want to chime in?
Yeah, thanks. I think some of my first point probably overlaps with John. We use similar terminology and words, but it's getting to the point of scale, and some of the interventions have to do where you seeing come in, of course, but also I go back to the point I wrote in the chat earlier, and that whole process of implementation. And again, just looking at a lot of the work we've done on introducing labor companion or other quality improvement or increasing community engagement. Again, sometimes, particularly at facility level, that whole way of just having management speaking to the providers, hearing their concerns, showing that they're addressing them, that kind of approach makes such a change itself. It doesn't show up as an intervention, but it itself, that whole maybe participatory management philosophy is such a game changer, and it's not one of those things that ever get documented. And I say the same thing working at community level, the whole way of approaching it, that's more of, John used the word co-production, and doing this together, again, doesn't come out in literature because we don't document processes, we just kind of need to document the outcomes, but missing that, I think, really in an intervention like this would be helpful. And then my second point was just around, I see the word postpartum period, and I just wanted to know, I missed the beginning, and I was wondering if it's respectful maternal and newborn care, if we're talking about, this postnatal period. And, we're just finishing work, a big scoping review to look at measurements of experience, of satisfaction, of respect and mistreatment for the newborn to complement all the maternal work. And I do think there's some things that maybe we don't normally look at for the newborn that would be interesting to consider, that have come out from this, that you might want to think about your terminology here. Again, if newborns to be included, then we should be talking about postnatal. We should just have some things that are sensitive without taking over the woman's space and in her domain. So again, that's kind of a lot of that's been discussed and worked out in the new charter. But I was just wondering, for you taking it forward, if that's going to be integrated, then you might just want to think of some slight additions and changes that help to reflect that.
So one of the things which I want to say is that, there is no platform basically where, postpartum women can come in. So actually majority of the platform is for the baby, or, they come for immunization like that. So that is one of the major problem which we have. I think that if that is basically, if we have, because an antenatal checkup, you have a platform, right? But for postnatal care, there is no platform as such. Basically we ask them to come to the facility. So I think that's a major problem.
Okay, I think we're in our group. And I'm sorry, I think we're cutting someone off who was speaking. Was it Dinesh? Were you going to comment there?
Yeah. So what I was telling was that we have a lot of items on the table, which we are having this, and somebody has already remarked on that. I think it will be better if we can have some scoring system where, if we score this on a scoring system, and if there is a high score, we take it as a, as an item which needs to be approached or, taken up. So I think some criteria, some sort of a benchmark. Otherwise, there is too much on the plate. I think it will, and quality of care and other things will, and when we tell also, it will not be practical to, go ahead and basically address all of them, because these are huge amount of it's all the universes we are talking about. But what are the various low hanging things which we can approach, and in especially in low and middle income countries, it will be very, very important that what are the low hanging and what is the feasible things which we can do. So I think that's very important.
Absolutely. Some of the criteria we've been thinking about and the direction we're going in is, I think your feasibility question and sort of ease of application. And I think other people had mentioned applicability to scale or thinking of designing for scale from the beginning. Relevance for an SBC intervention, we're not, some of the interventions we could do in the workplace wouldn't necessarily be around social and behavior change. They might be more structural changes, although they'd have an influence on social and behavior change, but keeping that element into consideration. I think we are trying not to duplicate efforts from other projects as well. So I think we are thinking of what are the most relevant factors, interventions and tools for postpartum period. And then that element of trying to design an intervention that would have great outcomes, not only for client, but also for provider, which seems to be, according to literature, an area that's less well focused on. So those are some of the criteria we've been thinking of, but if there's others that people want to put on sticky notes or into the chat, that's also really helpful as well.
I think there's a question from Carol. Are financial incentives to be understood as being distinct from getting paid regularly? I think just to answer that quickly, and then Jessica, you can jump in, from the research that we did, from the reviews and the systematic reviews that we saw, and the overall interventions that we saw, we did come across a few programs and interventions where they were giving financial incentives or monetary rewards on top of wages and salaries to incentivize providers at a provider level, of course, and then at a facility level to be able to give respectful care to improve the quality of care. So we made that distinction when we talk about our programmatic efforts. Yes.
And did the literature say whether those incentives were necessary because the providers weren't being paid fairly and regularly? I asked that because it just seems
yeah, so I think one of the studies that we looked at was done by Pop Council on in Bangladesh to improve the care to new mothers. And I think it's the literature didn't talk much about whether the performance was adequate or not, but just that the intention of the intervention was to improve quality of care and to encourage respectful care. So rather than saying that this was something that wasn't done before, it just felt more as an incentive or felt more as a motivation for better service delivery and improving respectful care.
I think across health areas, this question of incentivizing providers, whether through financial or intrinsic sort of motivational incentives, is a question, and then it begs exactly the question you asked, which is the normal status quo system not sufficient? And there's definitely a lot of considerations to think about, right? So if you do introduce financial incentives, a lot of the performance-based financing incentives that we see coming from World Bank, for example, once those projects end, then what happens? Does it have unintended consequences afterwards? But I think that certainly something, particularly if we are focused on provider outcomes, is something we should be looking at more. I'm going to have to bring us back to the regular group because otherwise we're going to be late to get everyone back to the rest of their day. So thank you so much for all of the great discussion, all of the great information that you put on the slide. I'm going to close the group out now and bring us back for next steps. Thank you.
Can I just add, this is Charlotte from Pop Council. We have done stuff on provider motivation, and we have seen that where the providers are part of a team and are appreciated by their managers, that they provide better care. And we have a paper that will be coming out sometime this year. But I think it's a really critical thing about the teamwork and the support and having agency to be able to do things that they're trained to do. It's a huge issue, but yes, I can talk more on that another time.
Yeah, and you said the paper might be coming out in the next few months. If there's even any drafts that you'd be able to share, that seems like a really interesting and relevant topic, and also just
yes, potentially, yeah. If you email me, I can see what we can do.
Okay, yeah, no pressure. But yeah, that's really great, and seems to be such an important topic.
Hi, everyone. Thank you for joining us in this smaller group. Not that you had a choice, you were pretty much put in it, but really glad that you're here with us. And thank you for those of you putting your cameras on. It's so nice to see your faces. I don't know about you, but I hate working from home. So I want to connect with you all and really appreciate you putting your cameras on, but no pressure. I mean, we're all kind of spent at this point. Hi, Kathleen. Okay, great. So you have the link to the Jamboard in the chat, but again, no pressure to even bother with it. Tina's going to share her screen. You don't need to add anything in. We can take care of that for you. I think we're all at a point where we want to ask less of you. So given how busy everyone is, we are happy to take some notes. I just wanted to highlight, and maybe Tina, we can move it or make it a teeny bit smaller. This is small fonts. Forgive us. We're gonna, send all of these things out after as well. We really struggled. Like, there's so much to cover, but we don't have a lot of time, and we don't want to waste your time. And many of you have written some of these papers, so you're very, very familiar with the literature. But we wanted to kind of use this time together, which is becoming shorter and shorter, to think about what are the gaps, right? You're already doing a lot of work in these areas. So that is the goal for this session together. So I guess, Tina, if you can make it a tiny bit bigger, I'll just talk it through. I don't know how useful this will be. And you guys all have access. So if you want to go in, you can enlarge the screen to see what's there. There are just 3 slides I want to give a brief overview to, and then we'll definitely chat amongst ourselves. So the first page here is on influence factors related to the provider that we found in the literature. And so you see sort of on the left column, the influence factors, socio-demographic factors, which, gender of provider, obviously we don't intend to do anything about that. But when we look down the categories, there are some things that, we want to pay attention to. Provider bias towards client attributes, where providers are seen to be more abusive to women who are seen as rural or poor. This kind of, the social determinants and the power imbalances that are at play. And these things I'm sure are not going to be new to you. I just want to ground us in kind of what we're looking at. If we look at the third category, stress and fatigue, we find in the literature, a huge amount around work-related stress, fatigue, burnout. And of course, that stress and that fatigue and burnout results in decreased empathy often, sometimes detachment from the job, and also decreased job satisfaction for the providers themselves, let alone how that translates into the care that they're giving to clients. Professional experience, this idea that sort of encountering sickness and death, and that can really take a toll over time. Training and competencies, we know training remains important, but are we really maximizing some of the training and supportive supervision to address these very sticky, complex things like curbing bias, and looking at different ways of dealing with clients when you yourself may be completely spent? Work satisfaction, I think this is a huge piece. Low levels of satisfaction, again, these are many obvious points that people become demotivated, and that, of course, it affects experience of care. And then these hierarchy differentials that we talked about a bit before, differences in socioeconomic status, if you're treating a young mother, versus an older mother, there may be some differences. So again, I'm going through these rapidly, but I hope this is okay. Many of you know this stuff, better than I ever will. So I think I just want to ground us in what we found in the literature. If we move to the next slide on the Jamboard, here are more of these workplace considerations. Weak leadership. There was a point in the chat, are we talking about the people who supervise providers? Absolutely. This leadership results in a decline in clinical care, standards of respectful care. We have major challenges with the physical conditions as we move down these different domains here, and the factors around infrastructure, payment, staff workload, facility culture and supervision, training, again, that team culture. And all of the findings on the right side, are things that we expect and have seen, that poor working conditions, heavy workload, of course, impacts service. Facility cultures that don't hold providers accountable, or maybe not even hold the providers accountable, but don't support them. If they're feeling like someone is not really caring about them and it's quite punitive, these are all aspects, of course, that affect care. And then I'm going to just jump quickly to the last one here around health system governance. Standards for professional ethics. I read something recently from South Africa around, how providers are you know, they see disrespectful care among others in other providers, and they're taught and watch this stuff happen, and it's very difficult to kind of counter that. Even though some of these guidelines are in place, you know, there are major challenges there. Again, this whole bucket around provider training and what are the training areas. There's so many good trainings out there, but, you know, are we highlighting the compassionate piece, that human connection, and highlighting that it's mutually beneficial for both the client and the provider, and of course leads to better outcomes. And then finally, equipment. You know, we have there are problems with supply chain, these other systemic challenges. So, you know, that was a rapid fire overview of some of what we found in the literature that most of you know very, very well. And maybe we can move to the next Jamboard slide here. This again is just a reiteration of what Jessica had shared earlier. We found so many tools and resources and various elements of intervention designs already. So, you know, the spirit is we want to build on that, adapt some of it, maybe add to it. We need to figure out where our point of interaction will be before we can kind of settle on that. But there's so much out there already. We don't need to reinvent the wheel. So our next and last slide, where we'll spend the rest of our time together. With all of that, where are the gaps and opportunities that you see? You know, based not only on what's in the literature, which is of course essential, but on your own experience, where are some gaps and any thoughts that you have? So I will pause there and open it up to the group. And again, if you want to go into the Jamboard and you're more comfortable just adding a sticky note, you can go on the little square sticky note on the left. And go ahead and add it directly if you prefer to type, or if you want to prefer to come off mute. Yes, that's how you get to the sticky notes. Tina's showing us, and I'm sure many of you have used this platform before. But any thoughts or things that jump to mind, or even points from our earlier discussion that you didn't feel were adequately discussed? Please feel free to either raise your hand or go ahead, just take yourself off mute.
Lynn, this is Kama.
Hi, Kama.
Hi. I have no hand, so I can't raise it. I don't know where my
hand went. Go
my
ahead.
hand disappeared. One question I had, and that might be a gap, is this. I mean, I think of compassion and empathy as values that are much more challenging and take time to teach. If you can teach them, but there's challenges in that. And so I wondered if in the literature you found any difference between teaching what compassion and empathy looks like, so there's actions you take, versus actually trying to change someone's values that may be much more of a complex response to their own lives and the many challenges they experience in their own lives. I don't know if I'm being very clear, but I don't know if that was ever separated in the literature. So someone may still feel the same way about a rural woman. You haven't changed their biases, but you have trained them to at least present and act with what a patient or client might identify as compassionate care.
Thanks, Kemma. And Beth, I don't want to put you on the spot, but I wonder if you want to speak to this at all, given your work. If not, that's fine, but really welcome your input.
Hi, everyone. Well, thank you. Yeah, I have such a sort of a swirl kind of response to that, because thanks for asking it, Kayla. I think the problem is that compassion is such a complicated concept and construct, because it involves recognition, first of all, which means you have to be clued into the nonverbal as well as the verbal aspects, and be curious enough to want to know something about the patient's context and social setting. And it involves motivation, which of course, is very difficult to measure. It involves communication. It involves a lot of skills, communication skills around shared decision making and information sharing. And then it involves, actual action and follow-up. that's visible to the other person. So all of those things, there's no single construct or measure, really that's going to look at all of that stuff. So what's often done is proxy measures, usually done from the other person's perception, like you call them clients or patients or, things like that. And so that is measured in proxy in a lot of different ways. We actually have a scale that was is being translated in Ethiopia and some other countries around the world, the Schwartz Center Compassionate Care Scale, which includes some of these different things that I've mentioned that might be visible to a patient or a family member. So I think aspects of this are measurable. In terms of teaching it, I think the best knowledge or understanding we have, at least from my understanding of it, is that it's really all about modeling, a lot about modeling. You can train the communication skills, and sometimes the response of the person to you will engender even more compassion. And so some people argue, well, teach the skills and the values will follow. And that's actually not too uncommon, especially, I think that has been tried and true in people with substance use disorders, patients with substance use disorders and things like that. It's part of their change theory, but you can change certain skills, hope that the values will follow. But we talk a lot, to your point, one of the points that you made, that there's a huge, what used to be called a hidden curriculum, that people say what to do, but then they model something quite differently, especially, in American medical schools and things like that. So what trainees and young students and things see may not actually be what is taught or valued or upheld by teachers. So what they see on the wards or in clinical care, it is far more powerful and more deeply embedded in what then emerges as their behaviors. So it's called the hidden curriculum. I don't think it's hidden at all. It's in plain view.
Thanks a lot, Beth. Patricia, I see you have your hand up.
Yes, thank you. I'm not an expert on this, but on the work that I have done in the past, I have perceived that there is a lot of the social dynamics between healthcare providers and the patients, particularly when they come from the same community. So I am not just talking about in general, but our settings where you can see detachment or patients coming from different stratas of social stratas. But on situations like community health work or primary healthcare facilities where nurses or technical aides at health facilities live in the same complex where the patients come from. And although when they are neighbors or when one could think they can relate better with more compassion because of the situation, but sometimes it's a matter of power dynamic as well that prevents them from being empathetic or being more compassionate to their fellow neighbors. And so it's a very complex environment. And so I didn't see it among the categories that you mentioned, but maybe it was there. I just wanted to point out. And understanding the complexity, I think this is a process of interventions that will have to be multifaceted, but at the same time have to influence one to the other because of how the expectations from the community, not just from the patient itself, affect the decisions of the provider or doctors or nurses or anybody who provides the care. Nobody wants to be seen as non-responsive, but the responsiveness may not necessarily adhere to the nice protocol that we consider as proper practice. So there is a lot of going on in circle that will have to be done in terms of interventions, feeding one another before we can actually determine a linear pattern intervention behavior change. Nothing is linear in this life. So that's all what I wanted to say.
Thank you, Patricia. Really appreciate that contribution. And the issue of power is real. And, you know, the whole equity piece within quality of care is so important, but how do we operationalize that and make sure that we're actually addressing it? Really important point. So thank you for that. Anyone else want to come off of mute? I see some other things here added in the Jamboard. I don't know if anybody else wants to chat or walk us through either what you've added, or Tina, maybe you've largely been adding them. Sorry, I've been looking at people's faces and not looking at the Jamboard. Rebecca, please.
Yeah, I added something in pink in the upper right. And I think what we see in immunization is some cognitive dissonance on the part of health workers in terms of using alternative explanations for low continued utilization of immunization services, not completing the vaccination schedule after initial negative experiences of care. And, you know, from the health workers' perspective, this sort of makes sense. In immunization, we're kind of dominated erroneously, as it turns out these days, by the concept of vaccine hesitance. And in fact, that's kind of an easy way of shifting responsibility to the caregivers, to the mothers, for not coming back for care, rather than sort of seeing the connection between the health workers' own behavior and what actually happens in terms of continued utilization. So for us, the concept of dropout and dropout monitoring, even at health facility level, is actually a very strong tool, but the interpretation of those dropout rates remains a challenge.
Thanks for that. Really important point. Beth.
So I just wanted to get back to interventions a little bit, thinking in terms of some stuff that we're noticing, at least in the States. And one of the things is that, you know, there's pre-existing burnout well before the pandemic, emotional exhaustion, depersonalization, sense of lack of efficacy to make a difference. So that was rampant well before the pandemic. And of course, you know, I'm sure that it's just skyrocketed during, and we're having a significant problem with retention. And what we're seeing too, I think, is that healthcare providers are so exhausted and increasingly meeting with hostility around their messaging or their interactions in healthcare settings in the US, that they're very resistant to using words like burnout because it feels like you're blaming the provider. And so I want to suggest that an important thing might be to shift the focus on fixing the system rather than fixing the individual provider. And that has been just a raising hue and cry here in the States amongst the people that we're talking to. And so then the question is, well, what system fixes? And I just, you know, from my wearing my now kind of educator hat, I think it looks to me like from some of the business literature, whether this, you know, I think some of it pans out in healthcare as well, is that a very significant pivot point is the supervisor and the manager. So for example, on hospital wards in acute and long-term care settings, it's the manager that really sets the climate and the treatment on that particular unit. And similarly, amongst physicians, at least, the way, you know, a supervisor, department chair, or whatever, you know, if that person shows interest and wants to know about that, you know, person as their direct reports or whoever it is that they're speaking to, wants to know something about them as a person, encourages them, provides counseling, suggestions, feedback that's constructive and helpful. Those people, their satisfaction, their professional satisfaction increases, and they're much more likely to stick around. And they get less burnt out. And because we know that burnout is associated with medical errors and poor treatment and lowered patient engagement and lowered patient satisfaction with care, it has this enormous trickle and ripple effect. So if I were going to do an intervention, I might want to really think about.
Beth, I really apologize. Please carry on.
Oh, I'm so sorry. No, I'm talking too much. The only thing I was going to say is that it might be worth thinking about interventions that focus on that middle level. you know, of supervisors, department chairs, in the larger context, obviously, of everything you guys have outlined. But a training intervention might target that.
Excellent, thank you. Any other thoughts, reactions, or people want to highlight anything from the Jamboard or new additions? We only have 5 minutes, so yes, please.
Hi everyone. So I also put in some things in the Jamboard, but I just wanted to say, I mean, really appreciate this thorough presentation, you know, and I'm really glad that you're also looking at health facility factors. And I'm in the Jamboard, I put in like the basic enabling environments that you've so clearly brought out, you know, salaries or HR issues, all of that. So that tends to get neglected often. So I'm really glad that we're thinking about that. But also in terms of the health governance, more upstream health governance related factors, I think if we could also look at, for example, you know, whether quality of care policies exist or governance for quality, or even accountability for providing quality MNCH services, or mechanisms to engage communities in delivering services. So I think those are some of the other gaps that I just wanted to flag, but this is it's really exciting. Thank you.
Thank you so much. Kathleen.
Thank you.
Yeah, sorry, was someone else about to speak?
This is Charity. Sorry, my hand is not functional, and I just wanted to add that Charity from Population Council Kenya. I just wanted to add that one of the things that we may want to consider as part of the intervention is bringing in self-care tools. We have said, in the literature review, the communication is very limited, and we see that that brings stress to the providers, and the providers are stressed, and also the postnatal women are also stressed. And one of the things that make particularly the postnatal mothers get stressed is not knowing what to do with their young babies. And there could be all these interventions that are existing there, but the providers don't have actually enough time to explain. So as we think about the intervention, you could just think about simple tools that are existing there, that could try and explain women on things like how to put the babies to sleep, how to feed the baby. Obviously, there are several tools on breastfeeding, but these perhaps need to be simplified in a way that they can be available. There are also other tools that can be used to reduce the provider stress. I mean, where providers are trained on how to be aware that they are stressed, and know what to do when they are stressed, and so on. Just to emphasize that the health system gaps may be hard to cross, but important to think about how we can, the interventions can be innovative enough to accommodate self-care, both from the user and the two sides, that is the provider and the parent. Over.
Thanks so much, Charity. And you're reminding me, there's a video that WHO put out that it's really quite powerful. I'll share it in the chat when we all come back together, but it touches on exactly the point that you've just made. So thank you, really appreciate it. Kathleen, over to you.
Yeah, thanks for the thoughtful discussion. And in terms of provider compassion, very much agree on all that's been said. And I think the importance of the supervisory support, as well as the modeling. I think the other thing, and of course the larger system factors, which are so critical. I think the other thing that maybe I didn't see coming out as clearly in terms of drivers around provider behavior, and there was just a nice editorial on this in one of the American medical journals, which I'm glad to share, is just the enormous frustration that providers experience when they're working in, care delivery contexts that are really inefficient and poorly organized. And I think this is a huge driver, speaking as a provider, just, you're just the frustration that you feel when you're working in a system that is just making every task so difficult. So some of that just sort of efficiency, quality improvement really, I think, can go a long way to just relieving some of that enormous cumulative stress that providers carry on a daily basis. The other thing I just wanted to briefly say is I think that the first question posed in our chat about can a provider be compassionate while having implicit bias? I think when we're talking about discrimination and bias and really disparities in healthcare based on discrimination and marginalized populations, I really think we need to kind of call that out separately. And there's a lot of work that's done on addressing disparities, et cetera. And I think I would be very wary of sort of thinking that there's an intervention that's going to improve compassionate behaviors while providers are carrying very implicit bias that's not going to, in the end.
Let's see here. Okay, you're back. Great. I think we'll pull up the slides. We have about 3 minutes left. So I think we might not try to synthesize because I know at least in our group, the conversation was so rich in so many topics, we would not do it justice. I don't think I could summarize in maybe 1 or 2 points. So just know everyone on the calls that we really, really appreciate all that great participation and discussion. And we're going to pull up next steps. So next steps definitely include going through the recordings of this call, going through all the great discussion. We're going to be sharing the slides from today, which also has a wealth of information in the appendix for those that have time and interest to look at, but all of the great feedback. So we need to incorporate that into our thinking, share some slides. We'll share the synthesis of the conversation, some of the questions we weren't able to answer in the chat. We will get back to you with more information there. And then next steps more broadly for the project, we are still exploring different options for a country for our next consultation to do that co-creation and then move into some testing. So that consultation will be happening coming up in the next month or so. And then, as we mentioned from the beginning, so the real goal is to take all of this great information, move it from that more academic exercise into a design, co-design, piloting, and then designing a monitoring and evaluation plan for that intervention or package of interventions, which will be a very interesting exercise as well. A lot of information. I will probably pass it back to Lynn to close us out, unless there's any last comments or questions. And really just appreciate everyone's time today.
Thanks, Jessica. And thanks to all of you. We can't thank you enough for giving your precious time today and talking with us and helping guide us as we try to figure out where we're headed next. I also want to thank Christina Granger, who's on the call. She is our activity manager for this activity, has been instrumental in giving us feedback and guiding us. So, and thanks to each of you. If you have any resources, I also added a few other, this WHO video that I just find amazing that came up in our call based on Charity's comment, and the Schwartz Center has done so much amazing work we can all learn from. And this Freakonomics podcast that I also think there's a lot in there. There are many resources, but please, if you think we are missing something or you have ideas about where we should go, or there are resources that you want to share, we absolutely welcome them. And if anybody is interested in kind of keeping in touch, or if you have a country where you'd love to collaborate, we would love to hear from you. So thank you for your time, and we are at 10:30. So we will close out and share the presentation. I know John had asked for that, as well as a summary of some of our discussions after the fact. So thank you all.
Thank you so much. Hope you have a great
Thank you. Interesting discussion.
Thanks so much.